Let's go ahead and call the Human Resource Committee to order. There being no citizens wish to address the committee, then we will move right into the agenda. Our first item on the agenda is approval of the minutes from January. Are there any corrections or to the minutes?
Move approval.
All right. All right. Then moved and second. All those in favor of approval signify by saying aye. Aye. Opposed by nay. Okay. Next on our agenda is Ms. Walker on the policies. Okay. Since we have to do them one at a time, right? Okay.
We always ask that. We always ask that in hopes that you will say, no, you don't. You can actually do them all in bulk. One day, one day.
Okay, good afternoon, everyone. What we would like to do is do approval of the following HR policies. The first policy is HR 4800, performance appraisals.
Okay, are there any questions on the HR 4800? All right, it's been motion. The second, all those in favor signify by saying aye. All those opposed by nay. Okay.
Okay. Next policy is HR 100, job descriptions.
All right, are there any questions concerning HR 100 job descriptions? There being no questions, I will entertain a motion for approval. Okay. Second by. It's been moved and second. All those in favor signify by saying aye. Aye. Those opposed by nay. Okay.
Next is HR 3100, military leave and supplement.
Are there any questions or concerning the military leave and supplemental policy? There being none, I would entertain a motion for approval. Okay. Okay, been motioned by Chuck, second by Charlie. All those in favor signify by saying aye. And those opposed by nay. All right.
Last and final is HR 4700, 90-day orientation period.
Okay. Any questions on this? Now I'll entertain a motion for approval. Okay. All right. It's been motioned and second. All those in favor signify by saying aye. And those opposed by nay. Okay. Motion passes. All right. You're still up.
Yes, ma'am. Also, the grade. Do you all have any questions about that?
I won't have to get.
Why did it go out here? Okay. Okay. Is my orange approved? Is it okay for me to move forward? It is. Okay, wonderful.
The only thing that would make you look better in that jacket is if it was maroon. It is your color, though. Indeed.
Thank you, thank you.
It's a lot like other things right here. Sometimes it's the interpretation.
Exactly. Right, exactly.
I thought it was blue, and I thought it looked good. Chuck and I think it's great. We were debating whether it's blue or green.
All right.
We apologize for it.
I know it. I know y'all have had too much sugar.
It's fine, it's
blame it on
HR
that.
appropriate, so I mean, we're right in line, so.
All right.
Okay, well, this afternoon, what I would like to do is provide an update to the Human Resources dashboard. If we could look at the very top and focus on FY18 quarter 2. And again, as we go through this dashboard, our focus is benchmarking this data against Saratoga. So looking at the first piece here is total voluntary turnover. For quarter 2, we ended at 10.54, and Saratoga benchmark is 11.2. And that's great because we were lower than the industry standard for that total voluntary turnover. Next, we have involuntary turnover, where we ended at 3.93. Saratoga benchmark is 2.20. Total turnover is 14.48, and looking at the Saratoga benchmarks, we ended at 14%. Another piece is the one-year voluntary turnover. For the end of FY2, we ended at, for quarter 2, we ended at 17.8, and Saratoga benchmark is 17.90. So when we look at how we ended for quarter two, we're doing pretty good in these areas, looking at turnover overall as well. When we look down at the very bottom and we look at the job classes, and this is again done by our job families that we have within JPS. Again, this is the measurement period for October 1st, 2017 to April 30th, 2018. And this provides the overall turnover for each of the job families that we have. So when we look again, looking at the information that is provided and looking at the turnover, we're doing pretty good when we're looking at the benchmark against the Saratoga data. Are there any questions?
When I'm looking at the voluntary turnover, and I see in the police department, is there any reason that, have you identified any reason why theirs is high? Is it, I know we're competing with other police departments.
We are.
Okay.
And again, we have to think about it when we look at theirs because it's higher. The police department has a different measurement that they have to follow when it comes to end of employment. So we have to follow the state laws against that. So anything that occurs with the state laws, it supersedes JPS. So our policies do not have to abide by that. So if there's anything that is aligned with the state policy, we do have to move forward with end of employment with that group.
Now, if I'm thinking on the voluntary turnover is the one that we focus on, because involuntary, that's the one we are asking to leave. So on the voluntary ones is the one that we would be looking at, trying to keep them. And so executives is pretty high. I just wanted to mention that. So, okay. Anybody have any questions?
I've got a question. So the total number of vacancies for all these departments, and up at top, we have a comparison to quarter one and then to 17. The total number of vacancies, is that getting better or worse? Are we hiring more nurses, or is that shortage expanding, I guess?
Well, and when you look at the vacancies, again, looking at FY 17, we did end at 287, and then when we pulled this data through April 30th, 2018, that's where we ended at 335. But again, the vacancies, that's weekly data that we receive, and when I received that report last on Monday, we were at 291. So again, this is where the date was pulled, April 30th, 2018, and there are less vacancies than reported out here. To answer your question about nursing, right now is different modalities that are in that vacancy list. Nursing is really at a good point now because we do different recruitment fairs. It's not a high turnover for nursing, and they're doing very well. So we're coming up with different techniques, different strategies to be able to focus on nursing.
Well, I guess my point is, excuse me, at this point last year, did we have 175 vacancies? And the year before that, did we have 200? Are we hiring more nurses than that's leaving? I mean, what is the 146 vacancies, and I'm just using nursing as the example. Is it getting better, or is it getting worse by having more vacancies year over year?
I would say that it's getting better.
Okay.
Again, because that's where we partner very closely with our chief nurse, Wanda Peoples, to think about different ways. Of course, we know that nationally, everyone is struggling with, recruitment of nurses and, what are different techniques that they're utilizing to be able to attract individuals to JPS. So it's at a medium right now. It's not bad and it's not the best. Can it get better? It can, but I think everyone is dealing with that right now in the nation. But for us, we're at a good point with our recruitment for nurses.
Okay.
So maybe what we could do on that is next month, go back and look and see where we were 2016, 2017, to see if we really are moving the bar, or we staying where we are. I think that's your question, is that we know we're doing good, but were we that point last year and the year before? So maybe we can pull one of those out the next time and just look to see how we've improved for the past years. Okay?
Yes.
All right?
Definitely.
Okay. Yeah, DT.
I have a question on the information management technical. Is that part of the information technology team?
IT.
when you look at 27 or 28% turnover at the middle management level, it concerned me because of the IP loss, or are we hiring the right people, or are we not hiring the right people, or it's just opportunity somewhere else?
So let me explain to you these two job families. So when you look at management technical, is that what you're looking at? And then management, we put management technical because we have positions that could be director of processes, and they do not have people reporting to them. So for us to be able to distinguish the difference between management of people and budget, and then a person that does have a leadership position, that's how we look at the difference. Now, these could be project managers, it could be director of process improvement. That is the difference. So these are not truly leadership positions. That's why we call it management technical. And we picked that piece up when we did the market data, looking at what the industry was looking at, based on market assessment. So that's how we were able to distinguish the two, because it's a complete difference when you look at, leadership, management of people and budget, and then you may have someone that has that title, and they may just be management of a process.
But that is concerned too, because they're the one that manage the workflow and the task, right?
Yes, and it's different across the organization. I mean, it could be manager of business management, business analytics. It's all different types of jobs that fall into this job family.
That's why it jumped out at me. Is it alarming that we need to help them focus to see how do they retain people or recruit people because we have unfilled position? That's one. Because at some point, it's going to be a toll on the leadership team or the people below, because they have to take over those tasks. But
Okay. Definitely.
Let me speak a minute to the executive side, because I think it is important. If you're doing, in my opinion, if you're doing the right thing and you're bringing in the right executive team and you're bringing strong executives in, you're going to get cherry-picked by a lot of other organizations to want those executives. And that's where you're going to get your voluntary turnover. The other thing that I appreciate this board so much for, and I think will have an impact, is your process of looking at retention and the things that you've put into place that Bill will come up and discuss later for the annual incentive and the long-term plan. We're an organization that has never had one of those. So if you're part of this organization and you're doing really well, you're going to get noticed industry-wise. And when you get, Wayne Young's a prime example, you're going to get noticed industry-wide, and you're going to have the opportunity to go somewhere else. And you're going to go somewhere else that's going to probably significantly change the salary and a title in that case. So to me, it's an odd situation, because if you really are doing well, you have more of an opportunity of others wanting your good folks. So what you got to figure out how to do is, how do you maintain and keep those good folks? And as we've talked about before, people look at the public hospital and say, well, it's just the public hospital. Why would we have that pay scale, or why would we do this, or why would we have that retention? You don't compete with other public hospitals.
No.
You're competing in this market with Baylor and HCA and everybody else. And quite frankly, I like THR and HCA and Baylor. I just want better people working here than work there. And I want the best people I can possibly get. So when you have those executives, it is a challenge. It's constantly a balance. And then I think to the involuntary, I think the demands that are placed upon us as an organization is for you to be doing your job and do it well. And if you don't, and that's not a fit, we're probably not going to wait 6 years to go through that process. We're going to say, you know what, there's probably a better fit for you somewhere else. So it is a challenge, and I certainly, Dorothy, don't mind you bringing that up, because it's concerning. Those are high numbers, but it's a low percentage of people, and it's 22, and then you try to figure out when you lose 3 or 4 or they go elsewhere, your stats look pretty tough. But my biggest comment is I applaud and thank the board for putting a program in place that is a hopeful attempt to retain those people.
That was one of,
Excuse me.
Go ahead.
We all have different business models that we manage, but I've known in my career over the years, usually when my competitors are coming, they're coming from my top people. They're not coming from the person I'm saying This one doesn't do very good. They always seem to come for the top. So again, I think your point's well made, Robert.
It's a good time for us to look at that because we set the long-term TIF in to address that. So that might mean that we have to go back and look at that, because if that's not working, that was the piece that we put in place to kind of hold them, so.
Well, and just now, you just have your payout. So now people will start seeing
Seeing
that.
the
Right at this point,
actuality.
we've had a great deal of discussion, and we've talked about it, but we went from zero, we had nothing, and everybody understood. I'm actually fortunate to be able to keep the executives we had with no type of a plan. And I'm proud of them. But now, we've talked that, and now they'll start seeing that, and now we'll see, hopefully, the benefits of that, because up to this point, there's been discussion, and some of the execs didn't even know what kind of payout they would get during that time period, because you don't quite know. So now we're getting to our first year of that 3-year payout. Now we'll start seeing, I think, those retention numbers look
Right.
better. It'll certainly be a more difficult case. Now, in some of those cases, when there's a huge bump, you
Yeah.
can't even compete with that. Or let's say, just guessing, let's just say we had an executive and somebody wanted to provide all their children free schooling. I can't compete
No.
with that. So there are some things that we can't
can't
compete
do.
with.
Yeah,
A quick follow-up question.
Yes,
On
sir.
the information technology,
Mm-hmm.
the turnover and all that stuff is pretty low.
Mm-hmm.
Does that include people that we insource or contract?
No, that does not include individuals that go through contracts. So when we're capturing this data here, it's all of our active employees that are on our JPS payroll, not anyone that is brought through an agency or any type of contract. It's our people that we're focusing on. Because when you look at contractors and you look at agencies, again, when they come in, they're coming in to focus on a project, they're coming in to focus on a plan that needs to be initiated quickly and then turn around. So we don't capture that data. And then just looking at industry standards within healthcare organizations that I network with closely, they're not capturing that data either. So when we do this, we look at it on a best practice method.
The reason I'm looking at this is the cost of onboarding, right? Do we have concern with outside entity for onboarding?
Do we
We're trying to get-
have concern?
If they have turnover themselves,
No,
And the
we
effectiveness
don't
of
have
us.
concern, but that's why we focus on, number one, before we even go to an outside agency, we communicate and ask leaders to utilize our process first, to give us time to be able to save dollars before we do go to an agency. So whenever a vacancy does come open in the position, that's where the talent management team does meet with the leader to have that conversation on, what are they looking for, what type of talent, what are key initiatives that are currently in place that they need to work on, and let us utilize our pool first. Let us utilize our recruitment before we do go to an agency. So we focus on our in-house before we go outside first.
the reason I'm zooming on this one, to tell the truth, because this is the area where the intellectual property and the process is so important, because this thing happened, will mess up every department, because we depend so much on our system, and
Right.
all the WeWork and all that stuff that we're trying to help other area. That could be just the noise coming from certain area. That's why I'm zooming on this one.
Right.
So just a thought around it, to make
Definitely.
sure that we bring that level down
Yes.
for the entire team
Okay.
on the other side.
What we want to make sure, DT, is when you ask a question, we always like to have a big drill going on outside, because it really does help a lot. Yeah, so that's, we make sure as soon as DT talks, we have a big drill going off in the hall.
And then one other thing too, Roger, to be able to piggyback on your question, we did get the data for the total vacancies. So when we ended the year, fiscal year 16, we were at 474 vacancies. And then when we closed the year, FY 17, we were at 287. So we have improved. Yeah.
any other questions? Okay,
Okay.
thanks.
Thank you.
Yeah. Okay, Bill?
You still got morning.
Little bit of time. So my purpose in presenting today is to discuss where we are relative to the annual incentive plan and the metrics that this committee and this board approved in January of this year, and talk next about the long-term incentive plan that Robert had previously referenced. I've tried to give you a visual, informative snapshot versus looking at the individual numbers, and I probably need to forward that. So intuitively, green is good, red is not so good, and yellow is making progress, right? That's the intent. So we have these 10 metrics, and these metrics are by and large metrics that we've seen before in the years past. The 2 quality metrics we have changed this year to focus on our surgical site infections, both from an abdominal hysterectomy point of view and a colon point of view. Taking our historical performance, we have presented, and this committee agreed, to look at a threshold level of whatever actual was -1, and then setting statistically significant improvements at the target and the stretch level. So this is through March, so we've got yet 6 months to go, and these numbers could change. We hope not, because we think we're doing pretty well in those 2 areas. One of the most significant improvements we've made, I think you'll agree, is improving days to next third, next available new patient appointment. We're at 10 right now out of 14 clinics, and that's dramatic improvement. We have recognized a problem with our specialty clinics and thought it would be a very good focus for us this year to improve that flow. You can see it's still red, but this is through March, and April results have begun to show some traction. I think we're in the low 90s as of April. So we hope that we can hit at least threshold when it comes to the end of the year. Service, HCAHPS, which is our perception of patient perception of service and care relative to the inpatient side, is right at the threshold level. CGCAHPS, which represents our overall perception of care in the clinics, is a little bit above threshold. We've got some ways to go. And ED CAHPS, that speaks to the patients in the ED, exceeded all of our expectations, and they're certainly performing well above the stretch target that we have in place today, in spite of the volume that we've seen. Yeah.
If you look at where this place was.
Sharon reviewed with you the FTEs per adjusted patient day in the Finance Committee, and we're performing well there, below budget, and certainly above our stretch target. Operating margin, we're right there at the threshold level, and I think this was through March. I think if you look at April, which many of you were in the Finance Committee meeting, saw that there was a little improvement in our bottom line. I think we're right at threshold at 0.2%, meaning we've got a lot of opportunity before us over the next now 5 months since she gave you the April report. Cost per adjusted patient admission, not doing so well here, and that's part of our long-term incentive metrics, which we'll discuss on the next portion of the agenda. Achieve and maintain high levels of employee engagement. That survey will not take place until August, and we won't know the results until September or so. So we assume that we're going to do well. We've done well the last 2 years. There's no reason to believe otherwise. But that gives you some sort of a feel where we are mid-year on our annual incentive plan. And to remind you, that plan is for directors, managers, and above, eligible for 10% of their base salary. Everyone in the organization participates, and those below that level would be able to participate at the $500 per employee level. So I think we're making progress. Now, the next portion of the AIP.
Bill.
Hold on a minute, Bill.
I'm sorry.
DT had a question.
On the perception of care,
Uh-huh.
I would throw your lifeline here. Because we at 72, and we target and stretch is 79, at what point do you think we have to level off because of, we have building, perception of an older building and all that stuff? Just talk to us about to see where is that reasonably will kind of level off.
We plateaued. 2 years ago, we hit the 78th percentile. And NRC Picker, which is our vendor for the surveys, led us to believe we could expect that once you peak at a level coming from a much lower level in a very short period of time, you're probably going to see some recidivism in your scores. And we did. We dipped below the 72nd, went down to the 71st, bounced back up. We're seeing results as they told us that we could anticipate based on their previous relationship with institutions all over the nation. So some months were a little bit better. Some months, it seems like we're in that level, that we fall back to this particular percentile. And this is percentile ranking, not mean score, right? And this just, to me, validates the fact that we have to continually work on this, because you've seen PIA's report on voluntary turnover, involuntary turnover. We've got people coming in all the time. This is an area that you constantly have to pay attention to. You have to train, and you have to validate, and you have to observe, and you have to shadow. And in spite of doing all that, which we've done, we still hit these kind of levels. But I think it too speaks to the fact that even though we have a facility that's outdated, we're still able to achieve relatively high levels of patient satisfaction. And when you think about where we were 5 years ago, I don't, but it's a fact. We've come a long, long way. Do we have opportunity? Do I think we can do better? I want to believe that. I do. We just need to be more consistent.
I'm more looking at from a different perspective, things that we can impact, like access, co-pay deductible, asking for questions about their payment. Obviously, they're going to give us a different rating, interaction with the doctor, the nursing staff type thing. Those that we can improve scheduling, with building and certain physical things that we can't move the number. Should we take a look at that and try to understand so that we don't have falls?
I hear what you're saying. I do. And I think the fact that we do have the majority of our rooms are semi-private, that probably, I don't have validated research results on that, but that intuitively you would think if I were in a different environment and I didn't have a curtain separating a bedmate, that, yeah, I might feel differently about the organization, right? I think one can draw that conclusion. Most organizations today don't have the predominance of semi-private rooms that we do, right? So that just implies that we've got to be a little more vigilant and diligent about how we relate.
To that point, DT?
Just looking for impact and not something we can't impactable. I mean, that's nothing we can do. Right?
Sure. There are some things, sort of that same way. Our challenge is on the second floor, and Dorothy has talked about this and become such an advocate for it, but when you're in that kind of a setting and you're waiting for your appointment, you're in an uncomfortable position, you don't like sitting in the hallway, it's even more difficult to get that patient SAT scores, and we can change that. I mean, that is a facility change, and I'm not just saying we just need to look pretty. I'm saying that makes an impact on the overall care that you perceive you receive, rather than sitting in a hallway waiting for your appointment. So your point's right on.
I know we improve a lot, but sometimes when you don't move the number, it makes it harder for the environment.
I agree.
All right. And this is our third year into this, and I've asked Steve Sullivan to kind of be at our next meeting so that we can really look at our trend. There are some things that are pointed out. I went out and looked at, compared us to other hospitals that have all the private rooms. In some of those numbers that we're saying, we're plateauing, they got all the private rooms and we are still better than them. So I know we talk about that, but if you look at, and you can pull up the several of the hospitals and compare them, in that number, we are right there with them, and they already have all the private rooms. So I'm thinking it might be something else. And so at our next HR meeting, I'll have a different graph for us to look at, and then for us to do some deep dive in some stuff that's going on and talk about where we want to be starting in
Did you compare
next year.
other community hospitals or private?
Yeah, well, we have I can compare us to Scott and White. I can go into, it's all out there on the internet, and compare it to other private hospitals, Harris, the ones here. I can do it, look and see what Scott White's doing, Breckenridge. Yeah, I can pull all that up and we can look at
Yeah,
it.
these are mostly lag indicators that are publicly available, so they've got some age on them, but it's,
And you can drill down
still
and it'll
true.
tell you what month they are. It's from 17.
Right.
So, but we can look at that. And so I've been trending that. And that's kind of part of the information. When we look at it, we can have some other hospitals that say, this is what they are. We're doing good, but there's.
The next slide is still about the annual incentive plan, but it's a different way to look at it. So if you look at all of the individual metrics based on the weight of those metrics, collectively, the payout is based on the collective performance of 10 metrics. So this shows you, from a dashboard perspective, how each one of those are performing relative to threshold, target, and stretch. And collectively, it's 120% of target to date through March. Again, we've got 6 months to go in the fiscal year, but this gives you some perspective of potential payout if everything stays as it is today.
Any questions on that? Why is our primary care?
What was the question, Dr.?
Why is
Like the
primary
primary
care
care-
rate so low?
Where
Are
are you?
you back on service perception of care under primary care?
CG
under
caps?
CG cap.
Oh, I'm sorry, yeah. That has been a challenge for us for a number of years. We haven't seen any regression there. We've seen only improvement, and we continually struggle with getting that overall perception of care from the primary care docs, and we work with them greatly. So none of us are happy with where we are percentile-wise. None of us are. But relatively speaking, we're making some progress, not as fast as we had hoped.
Chuck, have you seen those questions that, the questionnaire that they call and ask they do follow-up on? Some of those questions are hard to, it's an absolute. It isn't kind of, if they say, how is it, if they put you at a 3, that just doesn't matter. I mean, if you're not at a 4 or a 5, and it's kind of hard sometimes, because I got one of those surveys, and I was thinking, okay, I can see why this would be difficult. But we are improving.
It's
But
a
I
lengthy
thought-
survey. It is.
It is.
But it's
And
standardized.
I don't know if everyone have looked at that. It might help us to understand it a little bit better if we kind of looked at that. And there are some questions there that it's hard for you to do an absolute on. So I have a feeling if, it's kind of like when we changed the evaluation here, we went from 1 to 5, 1 to 4. So you had to do something when they put that 3 in there. Folks just, I think they think they're doing us a good deal by giving us a 3, but it's a 4 and a 5 that we actually need. And so I think that's what's wrong with that form, but since they won't let us change
They
it, we
won't.
just got to figure out how to educate folks. When you get this, you need to be thinking about us in the 4 and 5 range. The 3 doesn't matter. And I think folks are thinking that's a good score, because I talked to somebody about their survey, and they said, oh, I gave them a good score. I said, what did you give them? A 3? I said, oh, no, that was not a good score. And they said, but it's 1 to 5, and a 3 is good. I said, only in school. So I think that's a part of that education that we've got to do.
But we are precluded from coaching them because
Well.
they say we can't do that, right?
I know, but isn't there, I was, when you get the survey, I went to my doctor's office, and they gave me a little information sheet that said I would be getting a survey. And all it said is the scores, this is how they ranked it. Now, I don't know if that's right or wrong, but that's what they passed out well, they didn't pass it out, it's in a little waiting room. I thought that was, I don't know if it's cheating, but that's what they had in their waiting room, is something like, you will be, as a follow-up, you will be getting a survey. It's important that you answer the survey. And they just talked about the scoring for it. And 3 would not be counted. I remember that extinct. I'll try to find it.
You're going to give me a 3, don't send it in?
Dorothy, it wasn't cheating, it's just being communicated with. and
Well,
properly.
I'm just, that was what was in the waiting room, so I thought, oh,
She
okay.
can't fill it out as conflict of interest.
That's right.
Okay. Any other questions on that?
Okay. The next agenda item is to discuss the long-term incentive plan, and to refresh your memory, there are 2 metrics, and this is a 3-year plan, and Robert referenced that a few moments ago. We're in period 3 of that 3-year plan. There's been no payout whatsoever. This is designed to be the average of the performance over the 3-year period, right? The first 2 years are in the books. They were different metrics. They were reducing potential harm and ACSC type metrics that we proposed in latter part of last year and early in January, that those weren't metrics that were really sustainable for us, and you approved that. So we introduced 2 new metrics this year, which are going to be averaged with the previous 2 periods of old metrics, and these are more meaningful. This is about our measure of quality, and it's a leapfrog metric that is nationally recognized, perhaps not nationally embraced, but certainly nationally recognized. It's 30-some-odd metrics that roll up into a composite score. And we think that we could be in an A, should be in an A over the next few years, sooner than later. And we thought that another financial metric, which we need to certainly improve upon, is efficiency and productivity. And a good measure of that is cost per adjusted patient admission. So as you saw on the previous annual incentive plan, we're not doing well there. But in regard to Leapfrog, we just received the results of that score in April and are very pleased with the outcome. It looks like we're on that glide path that we had hoped we would be toward an A. We're not there yet, but given the progress and the accomplishments and the consistency that we've achieved, we truly believe that we will be an A in a very short period of time. But B was the target, and this reflects that achievement. And the final results for this come out in October. So this is kind of a preliminary mid-year report, but that's pretty indicative of what we might see in October as well. So we're hitting the target, a little bit above target if you interpolate on the Leapfrog metric, and we're certainly well below threshold in the cost per adjusted admission. So when you look at the next slide, which is similar to the AIP that I gave you from a dashboard perspective, a dial perspective, you look at period 1, period 2, period 3, which we are 6 months through. The overall award, if you will, if everything stays the same as it is today, would be 108.14% of target when you consider the performance levels of the previous 2 years and where we are year to date. So I'll be happy to answer any questions that one might have about AIP or long-term.
I have a question on the previous page, under the efficiency, something, hospital efficiency.
Cost efficiency?
Cost per
Efficiency,
adjusted
yeah.
patient admission?
Right. What are some of the key number that may move that number by $100 to get to that target point? So the salary, I know the salary benefit contract labor and all that stuff. What are the one that
What is the one
kind of,
leading indicator that might move that lag indicator, so to speak? It's going to be around salaries and wages, obviously, supplies, to the extent that our revenue, net revenue increases, that has an offset as well. So we know where we need to be. We just need to get there. And that fluctuates. That fluctuates fairly significantly from month to month, and it's probably not a good indicator to look at on a monthly basis, but on a quarterly basis, I think it pretty well gives you a good picture of where we are.
Any other questions? Thank you, Bill.
Thank you.
I think I have one more item, and it's just for information. And then it's our time. This is for my board, for all of us. It is now time for us to start working on Robert's evaluation. You know how long it takes y'all to get the information back. So we came up with a schedule this time. Robert is going to complete his self-evaluation by June the 22nd. And then we will send it out to the board shortly after that, and about the 25th, and that'll give you to July, end of July, to get your information back. Now, I'll be asking you for it, I know, in August, but we want to have it completed by September, so we won't go into March of next year before we get this evaluation. So came up with a little schedule, and so we hope to have this completed, and we'll be able to review it in September, because that's only fair that we do this. We continue and drag it out to the next year, but this time, let's try to, I'll just send you emails, and I'll just call you until we get it done. But we're gonna start it early, and Robert is gonna do himself, and that kicks us off, okay? No, I'm not about to do that, DT.
I think you're kind of saying offender. Even use plural. Yeah.
Yeah, and I can thank them real quick, and they'll know. But it's serious, and so I just wanted us to have an opportunity to cover it. Is there anything else that anyone needs to bring before the committee? Okay, there being none, then we are adjourned.